Good morning, everyone. I'm Ava Kadiwada. I'm one of the chief medicine residents this academic year. Welcome to Grand Rounds this Thursday morning. It's my pleasure to introduce Dr. Cynthia Herrick this morning. Dr. Cynthia Herrick is Associate Professor of Medicine here at Washington University in St. Louis in the Division of Endocrinology, Metabolism, and Lipid Research. In addition, she serves as the co-director of Washington University's Adult Transgender Center Department of Medicine. Dr. Herrick's research interests are in diabetes and obesity prevention, environmental and socioeconomic determinants of health, and improving healthcare systems and transitions of care, particularly for patients with low socioeconomic status. She joins us this morning to discuss integrating social needs evaluations in diabetes care. Thank you so much, Dr. Herrick.
Good morning, and thank you for that kind introduction, and thank you all for attending this morning. I have no financial disclosures, and hopefully by the end of this lecture, you will be able to define social determinants of health, understand the current professional society guidelines and recommendations around incorporating them in clinical care, apply the evidence on food insecurity and cost-related medication underuse to the care of patients with diabetes, and create a plan to incorporate social needs assessment in your role as a healthcare provider. And this outline of the talk this morning, we will be starting with an overview of social determinants of health, what they are, how they apply to diabetes with reference to St. Louis specific data. We'll spend the bulk of the talk reviewing evidence on two specific examples of social needs with particular relevance to diabetes care, food insecurity and cost-related medication underuse. And then finally, we will review the National Academy for Engineering, Science, and Medicine's 5A framework for incorporating social care into healthcare with some specific examples related to diabetes-specific care. So the social determinants of health are defined as the conditions in which people are born, grow, live, work, and age. They are shaped by the distribution of money, power, and resources at the global, national, and local levels. And when we talk about social needs, we are talking about circumstances in which the social determinants of health lead to most health inequities. You can see here are one of the frameworks that has been released by the Centers for Disease Control under Healthy People 2020 that classifies some of the social determinants of health into neighborhood and built environment, economic stability, education, social and community context, and healthcare. There are other frameworks that have been released by other organizations. And this framework lays out a rubric for the way that we will think about social determinants of health in today's talk. All of the conditions on the left side of the screen are upstream social, political, and economic factors that have a profound impact on health. There are inequities that people experience based on their social identities related to class, race and ethnicity, immigration status, gender and gender identity, and sexual orientation. Additionally, the way our businesses, schools, and governments are arranged perpetuate many of these inequities, and these feed into the various living conditions related to physical, economic, and social environment that affect health. All of this occurs upstream of where we sit in the healthcare system. And while we may see people for wellness visits and screen for risk behaviors, we're often catching people at the point at which they have already developed chronic disease and are needing to manage this. What we must recognize, though, is that the risk behaviors and the resultant diseases are ultimately in large part related to these upstream factors. And we have the opportunity in clinical encounters to take these factors into account, but there are many systemic changes, many which don't sit directly in the healthcare sector that we must advocate for as healthcare providers to improve our patients' health. Today, we'll start with an overview of some of the upstream factors, and then drill down on two social needs that can be screened and intervened in the clinical care setting at the point of care. And then we'll finish by thinking about our role in addressing social needs at the micro or clinic level and the macro or systems level. So there is a growing recognition among various professional societies of the need to integrate social needs into healthcare, although there has been relatively little clarity as to how this is best achieved. So the ACP recommends increased screening and collection of social determinants of health data to aid in the impact assessments, to aid in health impact assessments and support evidence-driven decision-making. The American Academy of Family Physicians recommends knowing how patients are affected by social determinants of health and helping to address their needs and to improve health. And the AAFP has assembled an implementation toolkit for how to do this, the Everyone Project. The American Diabetes Association recommends that providers should assess food insecurity, housing instability, financial barriers, social capital, and social community support, and apply it to treatment decisions while referring to local resources and incorporating self-management support from lay health coaches and community health workers where possible. And finally, the ACC-AHA in 2019 recommended that clinicians should evaluate the social determinants of health that affect individuals to inform treatment decisions. So you can see that each society provides variable detail with focus primarily on how social determinants of health affect treatment decisions, with some indicating the importance of resource referral. Despite the call for the incorporation of social determinants of health in the healthcare setting, the National Survey of Healthcare Organizations and Systems in 2018 documented relatively low rates of screening for all 5 social needs that were specified in this survey. This is likely higher now. This was a survey of over 4,900 physician practices and over 1,600 hospitals, and had about a response rate of 46%. Screening for all 5 social needs was reported by 24% of practices, 24% of hospitals and 16% of physician practices, whereas about a third of practices and 8% of hospitals reported no screening in any of these categories. It should be recognized that there are multiple different purposes for which social needs data may be used in a healthcare setting. They could be used to assist in determining an individual's health risk and incorporated into risk calculators for that purpose. They could be used in shared decision-making with the patient to determine a feasible plan or with the intent to connect that patient to community-based organizations to address a particular need. They could be used by health insurers and health systems as part of value-based care models and risk adjustment. And finally, through the collection of information in the health system, it can be used to inform both healthcare and non-healthcare sector policies that impact health that we can influence through advocacy. So while the details are not fully developed, the import is clear. It is critical to recognize, however, that there are barriers to implementation of social needs screening in a clinical setting. There are very valid concerns of patient mistrust of the health system and the importance of not introducing bias. There are patients that may not desire resource referrals, and that's okay. There's also the time crunch, as well as the difficulty of incorporating more screening into full workflows in the clinical setting, to name a few. But hopefully today, if nothing else, we'll give you a background in some of the evidence and a place to start. So to put this all in a clinical context, I'd like you to think about a clinical case, which is probably quite familiar to many of you in your clinical practice, as we continue through this discussion. And we will return to this case as we talk about the framework for incorporating social care into healthcare at the end of the talk. So this is a 43-year-old woman with class 3 obesity, type 2 diabetes, hypertension, hyperlipidemia, who presents for initial evaluation. She's been uninsured since her last pregnancy 5 years ago. She infrequently checks her blood sugars, but notes that some are as high as the 400s and others are as low as 50. And she's on metformin and a mixed Humulin 70/30 insulin that she is able to get for $25 at Walmart. Before we move forward, I'd also like to take a moment to reflect on the social scaffolding that we take for granted when we ask patients to manage their diabetes. Safe employment with a living wage, adequate housing and safe and walkable neighborhoods, with a lack of environmental exposures, education, and health literacy and numeracy are critical to managing complex medication regimens, food security to maintain a diabetic diet, childcare and transportation to accommodate office visits and lifestyle modification, and adequate social support and freedom from bias and discrimination. All of these are the scaffold on which we then build the complicated elements of diabetes self-management. We ask our patients to adhere to healthy calorie and carbohydrate restricted diets with fresh and non-starchy vegetables and whole grains. We recommend self-monitoring of blood glucose and adjustment of sometimes incredibly complex medication regimens requiring injections 4 times a day. We recommend 150 minutes of moderate physical activity per week. And we want our patients to see us at least 2 to 4 times a year for management, in addition to annual eye exams and foot care where necessary. This is a lot even if you have a full social scaffold. But if you add poverty and structural racism that break down the social scaffold, it makes all of these other things that we ask our patients to do incredibly difficult and at times insurmountable. So first, I'd like to address several of those upstream factors we referenced in the first few slides. All of these are interrelated and impact the patient's health. They are at the core of their ability to manage disease, but intervention at the point of clinical care is less feasible, and they require system interventions. The upstream factors we'll touch on briefly include socioeconomic status, which is a compilation of income, education, and occupation, social context, which encompasses structural racism and discrimination, and the physical or built environment, which encompasses housing and neighborhood conditions. There could be a talk on each of these factors alone, so this is just a brief overview. So first, I'd like to illustrate the connections between socioeconomic status and diabetes at the community level by using St. Louis specific geographic information systems data. As you can see on these maps from the Missouri Health Atlas compiled by the Missouri Hospital Association, the areas of St. Louis City and County that have the lowest median income here in the lighter green, higher percentages of individuals over 25 with less than a high school education, and the areas with higher rates of unemployment are also the same areas of the city and county with the highest prevalence of diabetes diagnoses. This association between socioeconomic status and diabetes is also well documented at the individual level through the National Health Interview Survey, where age-standardized rates of diabetes also increased at the individual level from 5% among college-educated and highest income individuals to 11% among those who had less than a high school education and were in the poorest income levels. Despite the fact that there is well documented a connection between socioeconomic status and diabetes, there is still not clear literature examining a change in income, education, and employment on diabetes outcomes specifically. And no diabetes outcomes reported from interventions targeting wage and early childhood education, access, and quality. These are difficult studies to do, but these upstream factors require system level intervention and study. And for an overview of the social determinants of health in diabetes, I would refer you to this scientific review that was published by Dr. Hilbriggs, Dr. Herrick, and others in diabetes care at the end of last year. So thinking back to those current maps of St. Louis with lower income and higher unemployment and lower rates of high school graduation, we must reflect on the history of structural and systemic racism that perpetuates these disparities. St. Louis codified race-based segregation in housing in laws and covenants in the early part of the 20th century. And in the 1930s, the New Deal created an entity called the Homeowners Loan Corporation. This organization sought to rate the mortgage risk on a scale ranging from hazardous, the red areas, to definitely declining, the yellow areas, to still desirable, blue areas, and best, green areas. The green areas were considered good mortgage risks, and these areas people received loans to buy homes. Whereas in the red and yellow areas, they were considered too risky to insure mortgages. And the largest deciding factor in this rating was race. The red and yellow areas were predominantly Black, and the green and blue areas were predominantly white. Additionally, Black families were prohibited from buying homes in the predominantly white neighborhoods related to these policies. This process of redlining was among the policies creating a pattern of neighborhood and housing disinvestment, making it difficult for individuals in these areas to accumulate wealth through home ownership and to purchase housing outside of these areas, even when the Fair Housing Act lifted restrictions in the 1960s. And while not exact, you can see that some of the areas deemed hazardous or declining at this time are still the areas that have socioeconomic disadvantage and higher diabetes prevalence today. This also could be its own talk. So thinking about the impact of structurally racist policies on the structurally racist policy of redlining on housing and neighborhood investment, let's discuss a few of the studies examining the relationship between housing, built environment, and diabetes. This can be difficult to separate from poverty and structural racism. However, the Moving to Opportunity study demonstrates the impact of housing and neighborhood on diabetes. This study randomized almost 4,500 women with children living in 5 cities in high poverty census tracts to one of 3 arms in the mid-1990s. The first arm received Section 8 vouchers usable in low poverty areas with additional counseling and assistance. The next group received unrestricted Section 8 vouchers with usual assistance, and the control group received no vouchers and usual assistance. And at the 10-year follow-up, there was a reduction in the prevalence of diabetes by about 4% in the group that received the vouchers to use in low poverty areas. Additionally, systematic reviews and meta-analyses of studies examining the association between built environment and diabetes demonstrate a 28% lower incidence of diabetes in areas that had high green space versus areas that had lower green space. And there were also lower rates of obesity, diabetes, and hypertension in areas with higher objectively measured walkability in these studies. But despite the importance of this community level data for understanding the needs of the community and for informing community level interventions, community level data don't necessarily predict individual level risk and social need particularly well. One study using OCHAN data, which is a collaborative of community health centers sharing their electronic health record data that are mostly located in California, Oregon, and Massachusetts. Over 36,000 patients were screened for social risks and answered one question during a clinic visit on food, housing, at least one question on food, housing, or financial resource strain questions, or financial resource strain. They defined individual risk in the study as derived from the risk reported on these screening tools in the clinic, and they defined community level risk as defined by census tract social deprivation index using geocoded address data. And the social deprivation index was a composite of 7 metrics from the American Community Survey, including poverty, education, single parent households, rental units, housing unit overcrowding, lack of vehicles in the household, and unemployment. They found that overall 30% of the population screened positive for one or more social risks, but using community level data to predict that risk was not particularly helpful. Using the highest social deprivation index quartile to predict social risk would have missed about 40% of individuals who had a positive social risk screen. And likewise, there were a number of false positives with a low specificity. So the community level data only accurately predicted positive social risk on the screening test or negative social risk about half the time. So for the next part of the talk, since this is a predominantly clinical audience, I'd like to talk about some of the downstream factors that are easily screened in a clinical setting, have the potential to directly influence management, and can provide a window into additional needs and opportunity for more immediate intervention. These are food insecurity and cost-related medication underuse. The critical role of health insurance will become apparent as we discuss both of these. Further, there are many components that we screen for among risk behaviors and disease that reflect upstream social determinants of health. And you could make an argument that housing, transportation, and utility needs can also be screened in the clinical setting and are actionable, but I wanted to develop a focus for the purpose of this talk. So first, let's talk about food insecurity. The USDA food security module is the most frequently used in studies and has the most validation data. It is used in national surveys as well and has multiple forms: the 18-question household survey, the 10-question adult version, and the 6-question short form. Questions on the 10-item scale cover things like worry about food running out, food not lasting, inability to afford balanced meals, frequency of skipped meals, eating less because of cost, hunger because of cost, weight loss, and frequency of not eating for a whole day. And the 6-question scale is a subset of these. Food security can be stratified into 4 categories: high, marginal, low, and very low. But in many studies, these are dichotomized as food secure being 2 or fewer answers positive on this scale, and food insecure being 3 or more answers positive on the 10 item scale. And people were considered to have a positive answer if they answered that they were, if this was often true or sometimes true. So the hunger vital sign is derived from the USDA food security module and consists of 2 questions, with an affirmative answer here constituting a positive screen, an affirmative answer on one or both of these questions. And again, this is often true or sometimes true is a positive answer. So the questions are, within the past 12 months, you worried that food would run out before you got money to buy more, or the food you bought just didn't last and you didn't have money to get more. This was initially developed in pediatrics, but has now been validated in the adult population using the 2013 Communities Current Population Survey Supplement. And they found that while specificity varied by households, with a slightly lower specificity among households with children and lower income households, this was quite sensitive in detecting people that were high risk for food insecurity. And this tool, as indicated here, is present in EPIC under the History tab or accessible during a visit in the Socioeconomic history. There are several studies that have examined the relationship between food insecurity and risk for diabetes, and food insecurity and diabetes control, and we will review some of them here. In a cross-sectional study using NHANES data, which is a national population survey, including exam and lab components, using the 10-question food security module, there were 4,423 adults over 20 years of age with household incomes less than or equal to 300% of federal poverty. Diabetes prevalence rates in this population were 11.7% among food secure individuals, 10% among mildly food insecure individuals, which combined the marginal and low food security categories we highlighted in the previous slide, and 16% among those with severe food insecurity. And individuals, sorry, this actually got displaced, but individuals with the severe food insecurity category had 2.2 higher were 2.2 times more likely to have diabetes than those in the food secure category, in a model that was adjusted for gender, race, ethnicity, income, family history, education, physical activity, and BMI. Another cross-sectional study using more recent NHANES data, examining adults with diabetes at all income levels, found a food insecurity prevalence around 12%. This population was predominantly non-Hispanic white. 64% of the population identified as non-Hispanic white, 16% identified as non-Hispanic Black, and 14% identified as Hispanic. And unfortunately, in these years, the NHANES did not separately define an Asian or Pacific Islander population. 10% had no insurance, and the mean duration of diabetes was around 11 years. About 20% of this population was on insulin. An inelastic regression model adjusted for many demographic variables as well as clinical comorbidities. Individuals with food insecurity were 53% more likely to have an A1C greater than 9%. Of note, in this study, not having health insurance was among the strongest predictors of poor diabetes control, with individuals without insurance having 2.5 times more likely, were 2.5 times more likely to have poor diabetes control than those that were privately insured. And importantly, those on Medicare, Medicaid, and other public insurance had no difference in poor diabetes control versus those that were privately insured. This study, having looked at some cross-sectional studies, this next study is a prospective cohort that was recruited primarily from a primary care network with a mean age of 62. Again, a predominantly non-Hispanic white population, majority privately insured on Medicare and using insulin. They assessed the effect of survey-defined food insecurity, so using the 6-item USDA food security module, and community level food access, which was defined as where low food access was defined as not having a supermarket within 1 mile in an urban area or 10 miles in a rural area. And the mean follow-up here was 37 months. You can see that those that were food secure at baseline and throughout the study on the survey module had a lower A1C by about 0.6% than those that were food insecure. But there was no difference between groups that were classified as living in a low food access area versus a high food access area. Reflecting back to the study where we talked about the fact that community level variables don't always reflect individual level need. And finally, a cross-sectional evaluation in a low-income population receiving care in safety net clinics in Chicago and San Francisco with high rates of food insecurity at 46% in this population increased the odds of poor glucose control defined as an A1C greater than 8% in this module. So you can see that those in the adjusted modules with food insecurity had a 46% were 46% more likely to have an A1C greater than 8. And the majority of this population identified as Mexican or Mexican American or African American. Most were on insulin, and insurance status in this study was not noted. Importantly, in the same group of patients, the risk of hypoglycemia was almost doubled among food insecure individuals, which is really not surprising if you think about people not having access to sufficient and consistent nutrition and being on insulin. Given that we see a clear association between food insecurity and risk for diabetes, as well as diabetes control in cross-sectional studies with a persistence over time in a prospective cohort, we might hypothesize that policies or interventions to mitigate the impact of food insecurity might be associated with improved control. One such study in a low-income population, again with high rates of food insecurity at 40%, looked at the effect of receiving supplemental nutrition assistance program benefits in mediating the association between food insecurity and poor glucose control. This was a predominantly non-Hispanic Black population that was predominantly female. Most had income less than 200% of federal poverty, and most in this population were insured with Medicaid, Medicare, or private insurance. 45% were on insulin. And you can see here that food insecurity was associated again with poor glucose control, defined here as an A1C greater than or equal to 8%, where those with food insecurity had more than twice the likelihood of poor glucose control. And there was a significant interaction by SNAP participation. So those that were food insecure and received SNAP benefits were 65% less likely to have poor glucose control than those that were food insecure and did not receive SNAP benefits in this population. So our group set out to examine the possible effect modification of this association between food insecurity and poor glycemic control by SNAP receipt in a national population sample. We utilized the most recent 10 years of NHANES data and defined a population of individuals with diabetes by self-report or a documented A1C greater than 6.5% by the NHANES lab. We restricted our population to those with incomes less than 185% of federal poverty, so as to capture those that were eligible or near eligible for SNAP benefits. Our primary outcome was defined dichotomously as poor glycemic control, but this target threshold was defined for the individual, accounting for both their age and cardiovascular and microvascular comorbidities, according to an algorithm that was recently defined in published work, as well as consistent with the ADA guidelines, allowing more flexibility in A1C goals. So for example, someone who was less than 65 with no comorbidities was considered uncontrolled if their A1C was above 7. But someone who was over 65 with comorbidities was considered poorly controlled if their A1C was above 8.5. So primary exposures of interest were food insecurity, again defined by dichotomizing the results on the 10-item USDA food security questionnaire, and SNAP participation defined as receiving SNAP benefits within the previous 90 days. We considered covariates, including multiple demographic variables, clinical comorbidities that had not already been used to define the individual's A1C goal, diabetes management strategies including diet, physical activity and medications, and health insurance and healthcare utilization metrics. In our population of 1,757 individuals, 30.8% had poor glycemic control, 34% had food insecurity, and 41% received SNAP benefits within the previous 90 days. Our mean age was 58, and our population distribution was 48% non-Hispanic white, 18% non-Hispanic Black, and 25% Hispanic, with a little over half of the population being female. While food insecurity was significantly associated with poor glycemic control, with a magnitude similar to that seen in prior studies, with those in the unadjusted models or the model adjusted for everything except for health insurance and healthcare utilization, those that were food insecure being somewhere between 38% and 46% more likely to have poor glycemic control. This no longer remains significant in the model where we added health insurance and healthcare utilization variables. As in prior studies, uninsured patients were 70% more likely to have poor control than privately insured patients, again, with no difference between those on Medicare, Medicaid, and other government insurance and private insurance. Additionally, in this population, SNAP was not associated with glycemic control on its own and was not a significant effect modifier of the association between food insecurity and glycemic control. These findings suggest that while food insecurity is an important factor in glycemic control for this low-income population, nationally representative population, health insurance is perhaps the most significant factor. And the lack of effect modification by SNAP participation may be related to the fact that SNAP benefits are not adequate to afford a sufficient healthy options, something that has come up recently as SNAP benefits have been expanded in the American Rescue Act. Or that healthy options are not incentivized specifically in the SNAP program. So finally, one study team has conducted interventions through the Feeding America food banks across the country to determine if an intervention providing nutritionist prepared food boxes and some other support services could result in improved glycemic control. Because these trials were recruited at the food banks themselves, the prevalence of food insecurity was high at 75 to 80%. A pilot study with evaluation before and after the intervention in 687 individuals with diabetes, about half of whom were considered uncontrolled by the threshold of A1C greater than 7.5%, found that A1C improved significantly from baseline to intervention end, as did self-efficacy and diabetes distress. There was also a significantly lower percentage reporting trade-offs between food and medication and supplies at the end of the intervention. However, a randomized control trial of 568 individuals in California, Michigan, and Texas randomized half of the population to the intervention, which was the prepared boxes plus support services versus a waitlist control for 6 months. And all of the individuals in this study were considered uncontrolled with an A1C greater than 7.5%. They did not demonstrate a significant change in the intervention group in mean A1C, cost-related medication non-adherence, food and medication trade-offs, but they did demonstrate an improvement in food insecurity, food instability, and food and supply trade-offs in this study. So the data on interventions and policies to mitigate the effect of food security on glycemic control are mixed, but there's definitely room for additional study and innovative cross-sector approaches. I'd like to turn now to another social need that frequently arises in the clinic and directly affects management, and that is cost-related medication underuse or cost-related medication non-adherence. In most of the literature, this is described as cost-related non-adherence. I will use these terms interchangeably here. I tend to prefer cost-related medication underuse, as this assigns, it has less negative connotations and assigns less blame or more places the focus of the problem on cost rather than the focus of the problem on the individual. So cost-related medication underuse or non-adherence is quite high among individuals with diabetes, affecting between 1 in 4 and 1 in 6 individuals with diabetes, and is highest among those on insulin. And according to data from the Behavior Risk Factor Surveillance System, the prevalence of taking less medication than prescribed because of cost was 16% among individuals among adults with diabetes. And factors associated with this cost-related medication underuse were health insurance, household income, and general health for those under 65, with depression, household income, and age being more prominent factors for those greater than or equal to the age of 65. Rates of cost-related medication underuse and the use of cost coping strategies, such as not taking medication as prescribed or asking for lower cost medications, vary significantly by insurance status, with uninsured individuals, unsurprisingly, having the highest rates. And in a study examining the association between cost-related non-adherence and health outcomes, this factor was associated with high all-cause and disease-specific mortality across conditions, including diabetes. So measures of general financial strain and cost-related medication underuse are frequently screened with a single question. In most studies, the general financial strain measure is during the past 12 months, how often did it happen that you did not have enough money to buy food, clothes, or other things that you needed, with positive responses being fairly often or very often. We have a similar financial strain screening question, again, present in EPIC, which is how hard is it for you to pay for the very basics like food, housing, medical care, and heating, with positive responses being somewhat hard, hard, or very hard. Medication-specific financial strain is screened using a single question. Did you use less medication than was prescribed because of cost, with options being yes or no? And sometimes this cost-related medication underuse is also assessed with questions about delaying refilling a medication or skipping a medication because of cost. Unfortunately, we don't have a medication-specific cost-related question in EPIC currently. So in a retrospective cohort study completed using the Kaiser Permanente Northern California Diabetes Registry, including a combination of survey, administrative, and electronic health record data, they found a relatively low prevalence of general and medication-specific strain. However, this population was insured and was part of an integrated health system, so does not reflect the population of the US as a whole. They examined the association between each strain measure with never filling medication, which they termed primary non-adherence, filling a medication, never refilling a medication, which was early non-persistence, and refilling a medication late. And interestingly, they found that medication-specific strain was most associated with never filling a medication in adjusted models, whereas general financial strain was most associated with refilling medications late. Nonetheless, both measures of strain were associated with some measure of medication underuse. Because trade-offs between paying for medications and paying for food often occur in individuals with diabetes, investigators looked at whether seniors with diabetes or prediabetes requiring medication in the National Health Interview Survey had a reduction in cost-related medication underuse if they were receiving SNAP benefits. They did this using a propensity score matching approach on sociodemographic and health-related factors. The population was predominantly female and about 46% white. And so what they found was that cost-related medication underuse was about 5% lower in the group that received SNAP benefits than in the group of older adults that the group that received SNAP benefits versus the group that was not receiving SNAP benefits. And you can see that here in the group of all older adults. However, this was not the case among those older adults who had no prescription drug coverage as part of a Medicare Part D plan, or who had very high out-of-pocket costs. And so you can see that SNAP benefits could potentially mediate the effect of cost-related medication underuse by helping with these trade-offs between food and medication. But this was not the case for those with very high medication costs, indicating that coverage of health insurance coverage of medication costs is really quite important. In another study, also using National Health Interview Survey data among younger patients, age 18 to 64, they did a detailed analysis of the association of multiple different metrics with those reporting financial hardship from medical bills. And you can see here, being uninsured was the strongest predictor of financial hardship, of reporting financial hardship from medical bills, with those that were uninsured having more than twice the likelihood of reporting financial hardship from medical bills in an adjusted model. But importantly, when we look specifically at individuals with diabetes in this study, they fared poorly compared to those with other comorbidities without diabetes on multiple metrics, even when those with diabetes didn't report financial hardship from medical bills. You can see here that those with diabetes and without financial hardship in the light brown bars, excuse me, in the darker brown bars, those with diabetes without financial hardship in the darker brown bars had higher rates of food insecurity, higher rates of cost-related medication non-adherence, higher rates of high financial distress, and higher rates of foregoing medical care due to cost than those that did not have diabetes, but that did report financial hardship related to medical bills. And that's in the lighter brown. And that those with diabetes who did report financial hardship related to medical bills had the highest rates, ranging from 30% with food insecurity to 55% who reported foregoing medical care due to cost. So Amy James, an investigator in the Division of Public Health Sciences here at WashU, conducted a detailed mixed method study examining cost-related medication non-adherence and trade-offs that people make with other basic needs. This involved a survey of 270 individuals in the St. Louis region who were recruited from federally qualified health centers, ads in the St. Louis American, and our tertiary care endocrine fellows clinic. To be eligible, individuals had to be aged 35 to 80, English speaking, with at least one chronic condition and at least one prescription medication. The survey covered a broad array of topics, including health coverage, health care utilization, medications, various measures of cost-related non-adherence, including delayed refills, unfilled medications, smaller doses and skip doses, cost coping measures, trade-offs between medications and basic needs, assistance program use, use of samples, and financial strain and food insecurity. And finally covered comfort with cost discussions among patients with healthcare providers. And in addition to the survey of 270 individuals, 52 individuals were recruited from this sample for an in-depth semi-structured interview to gain a broader perspective on how people made decisions around medication use and other basic needs. 30% of this population had diabetes, and of the whole study population, 80% identified as non-Hispanic Black, with a high, the whole population had a high number of comorbidities with a mean of around 4.5 and a mean age of 55. 2/3 of this population had a positive response on the general financial strain measure, and people with diabetes were more likely to have skipped a dose because of cost than those without diabetes. Individuals with diabetes were also more likely than those without diabetes to have ever talked with a healthcare professional about medication cost, to have filed for bankruptcy, and to have asked for and received samples. Additionally, individuals with diabetes were more likely than those without diabetes to report spending less on basic needs to pay for medications. And this was despite the fact that they were also those with diabetes were also more likely to be privately insured or on Medicare, and were less likely to be in the lowest income bracket in our study, which was a monthly income less than $800. Of those who spent less on basic needs, both among those with diabetes and without diabetes, 80% reported spending less on food and groceries, which is problematic, particularly with patients with diabetes, since so much of the management is nutritional. And if people are spending less on food and groceries in order to pay for medications, they may be being able to eat less of the healthy foods that are needed that could actually reduce their medication expenditures. When explored in an adjusted model, people with diabetes were, again, 78% more likely to report cutting back on basic needs to pay for medications. And I wanted to bring in just a couple of the quotes from participants in the semi-structured interviews to give you an idea of the individual impact of this need to trade off medications and needs, and the significance of how much we ask our patients to do with diabetes. So one participant said, "They give me medicine from Schnucks or a pharmacy and I can't afford it. So I have to go borrow the money or trade off the money with food stamps or something." And then another patient said, "Then you've got to buy the little needles, you've got to buy the little thing to check your blood with, you've got to buy that, you've got to buy the alcohol pads, and I should have brought the whole list of the things I had to buy." And in a final aspect of this study, these patients overwhelmingly reported being comfortable talking to a doctor about medication costs, with those with diabetes feeling less comfortable than those without diabetes, talking to individuals that had less clinical experience, such as front desk staff, medical assistants, or pharmacy technicians. This is important to keep in mind because I think sometimes as physicians, we worry about asking these questions, but it doesn't seem that this is likely to be a problem for most patients, particularly those with multiple chronic diseases. Remember, only 2/3 of those with diabetes and half of those without diabetes reported ever talking to a doctor about medication cost in this study. But over 80% here are reporting that they would be comfortable talking to a doctor about their medication costs. Some of this discrepancy may be related to a lack of need, but there's also an opportunity here for healthcare professionals to normalize this conversation. So finally, in the last few minutes, I'd like to frame the conclusion of this discussion around the framework set forth by the National Academy of Science, Engineering, and Medicine and our clinical case. The 5A's framework for incorporating social care and healthcare recognizes that some activities will be focused on individuals and others will be focused on communities, but everything begins with an awareness of the challenges that our patients face. Let's take a moment to walk through this framework with our clinical case. Remember, this is a 43-year-old woman with obesity and type 2 diabetes, hypertension, hyperlipidemia, who was uninsured, who was infrequently able to check her blood sugars, but had both highs and lows, and was on metformin and a mixed insulin that she was able to get from Walmart. So for awareness, we could consider designing our clinic workflows to utilize some of the routine screening tools that we've talked about. The hunger vital sign and a single financial strain question are in EPIC, among others. This screening could occur pre-visit with information provided on why the screening is being done and how it will be used, with positive screens flagged for discussion. We see that she is uninsured, so we know that this increases her risk of poor diabetes control. If we administered the 2-question hunger vital sign, we might determine that she was food insecure. If we asked about cutting back on or delaying refills of medications because of cost, we might learn that she had cost-related medication underuse. And if we normalize asking these questions and ask them of everyone, this can reduce potential stigma and bias while also allowing us to understand our patients' needs. And we can document these needs with ICD-10 Z codes with the Z59 series covering most of the housing, food, and poverty-related circumstances. And this is now considered in the medical risk attribution for medical decision-making in billing. Next is assistance. Knowing this information about food insecurity and cost-related medication underuse allows us to direct the patient to more specific resources, which may involve local food banks who have case managers on staff to assist with SNAP application. And we can explore 340B pricing for medications, pharmaceutical assistance program options, and pharmacy low-cost programs for medications. Your clinic social worker and social services resource locators, such as the Everyone Project from the American Academy of Family Physicians and United Way 211, can be very helpful in this regard. It is true that our patient may not be interested in referrals, and that's okay. There are a number of reasons that this may happen, and ongoing research will help us better refine how to best provide assistance to our patients. Adjustment refers to the shared decision-making that we can do with our patients when we have a better sense of their social needs. So for example, in our patient, if she has food insecurity, we would probably try to avoid mixed insulin because of the risk for lows, and discuss plans for times when food is more or less available, and realistically consider the types of food that are available. For cost-related medication underuse, she also reported a difficulty checking her blood sugar with frequently, and sometimes that's related to cost of supplies. And so we can encourage connection to resources like we talked about above in the assistance section, but we can also encourage an open communication about cost, inviting the patient to tell us when things that we send to the pharmacy are not feasible. Alignment refers to the connections among sectors, particularly the healthcare sector and social services. And one example might be incorporating social services resource locators updated with their capacity in the electronic health record to improve the referral process and closing the loop. Electronic health record, another might be for the pharmacy electronic systems to better communicate to the physician's offices when medications aren't filled and why in real time. My colleagues, Dr. Amy McQueen and Dr. Matt Kruder, have an ongoing randomized control trial with Centene, which is a Medicaid managed care organization, and their Medicaid managed care plan in Louisiana, examining the effects of social needs navigation through the insurance plan on diabetes outcomes for individuals with type 2 diabetes on Medicaid. So that's another example of aligning sectors. And there are food prescription programs and medically tailored meal programs in conjunction with food banks that could ultimately seek Medicaid coverage for sustainability. And finally, there's the integration of community health workers to assist with navigation, and that has been associated with improved glycemic control in a meta-analysis of multiple studies. The alignment of medical education curricula from undergraduate medical education to graduate medical education to continuing medical education with a social determinants framework is also critical for aligning social needs and the healthcare sector. And finally, we have a critical role as healthcare providers in advocacy. Because of our experience in the healthcare system, policymakers are interested in hearing from us. Medicaid expansion in Missouri was one current example. As we know, lacking health insurance has significant effects on patients with chronic conditions. There was significant involvement of healthcare providers in the advocacy efforts to get the amendment on the ballot, and then in messaging prior to the election to help with passage. And now there's an opportunity to be involved in talking to state legislators to ensure timely implementation and inclusion of this measure in the budget. Relevant to diabetes care, there are additional policies that could benefit from healthcare provider advocacy, including a discussion of expanding SNAP benefits, extending the SNAP expansion from the American Rescue Act, including healthy food incentives in SNAP, as well as advocating for insulin price caps, as have been done in multiple states thus far. And with that, I'd like to acknowledge my mentors, trainees that were specifically involved in the work discussed here, as well as trainees who have been involved in quality improvement projects in the Endocrine Fellows Clinic surrounding social needs, my collaborators, my research coordinator, and of course my funding. And I am happy to take any questions.
Thank you so much, Dr. Herrick, for taking us through all of that, especially that patient scenario there to make it relatable to what we do every day. To kind of follow up on that, someone asks here, I find physicians are often hesitant to ask social needs questions with the fear of being unable to do anything about it when a patient screens positive. Can you provide examples of how you as an individual physician react to and use such questionnaires in a visit with a patient to better your care?
Yes, so absolutely. I mean, and I think some of this is we need to integrate these questionnaires on a more, routine basis overall. And I will be the first to acknowledge that I have not necessarily incorporated it routinely, but it is something that I'm currently working on in my own practice. But I do, when I do ask questions about health insurance and food insecurity and additional social needs, it is with the idea to, connect patients, particularly in the health insurance realm. We can connect patients to applying for the Gateway to Better Health application, which, hopefully as Medicaid is expanded, will, roll over into the Medicaid expansion population or into Medicaid expansion and the Medicaid expansion application. So I will often point patients, to specific websites to start that navigation process, connect them with our social worker who can assist with that navigation process. We'll talk about the American the ACA Affordable Care Act plans and how to get started with that application process as well. One of the quality improvement projects that we have currently ongoing in the endocrine clinic is developing a resource list with a smart phrase that has local resources specifically for food insecurity, so that when patients screen positive on that, we can make sure that they're connected to those resources. We also have some smart phrases on the pharmacy discount programs and local federally qualified health centers, so that we can try to connect patients to services when needed. So some of those things are things that we've integrated sort of through the smart phrases in Epic. I think, ultimately it would be wonderful to have all of this integrated within the electronic health system, so you could go search for a service within that patient's area easily through the medical record. The social services resource locators that I mentioned, including the Everyone Project and 211, are places that you can go to, plug in someone's zip code and look at their need, and look at the specific need that they've reported and connect them to services. From the system level, though, we have to make sure that those organizations have the capacity to accept patients as well. So I think there are a lot of complexities here, but I do think there are also a lot of things that we can do in that patient encounter to help patients meet those needs.
Wonderful, thank you. Another question here is, have you seen or is there data that supports that telehealth has improved some of these barriers to healthcare, or is it more similar to SNAP benefits in certain patients just being one addition that doesn't necessarily eliminate the other barriers that patients have?
Yeah, I haven't, to be honest, I haven't explored that literature in depth. I do, certainly telehealth does eliminate the transportation barrier, which I think is huge. And certainly in my own practice, that we have been able to connect with more patients more routinely because of that telehealth. I think when you're thinking about telehealth, we do also have to think about the barriers to telehealth, which include, the access to internet that actually allows you to do a real-time video visit. And so, so I think there are possibilities there for potentially widening disparities, but there are also possibilities for improving our ability to connect with patients.
Great. I think this may be our last question here. So what are your thoughts about advocacy for the state legislature to fully fund Medicaid expansion?
Yes, so talk to your state senators. The Regional Health Commission has an advocacy blast that they send out weekly. So I would go to the Regional Health Commission and sign up to get on their advocacy blast. And there's actually a couple of discussions tomorrow on things that we can do. So I can update on what I find out in a Zoom meeting tomorrow on the most high impact things that we can do right now as healthcare providers.
Okay, well, thank you again, Dr. Herrick. I don't see any other questions coming through right now. If anyone has questions, you can feel free to send them my way or to Dr. Herrick herself.
Feel free to email me.
Yeah, thank you again for joining us and talking about this very important topic.
Thank you.